Silly Fishman, and welcome to our latest Facebook Live. I forgot I was doing Facebook Live, so I'm wearing a shirt. I had a tie, plaid. It's not plaid, it's kind of blue. Anyway, welcome. You see we have somebody complained that our background looked too simple, so we're having a new background every once in a while. Happy Halloween, whatever day today is, and Hannah drew that picture. It was not me drawing it, but Halloween is in a couple days, Thursday, so happy Halloween to everybody. I just wanted to, I'm running a few minutes late because I had a visitor. Some of you may know, it's actually a famous radiologist who was at Hopkins probably 16 or 17 years ago, Leo Lawler. Leo trained at Mallinckrodt, came to Hopkins for his fellowship, was on the staff, and then he went back, like many people from Ireland, they like to go back home. His family was there. And Leo's chair in one of the hospitals in Dublin, and he's an incredible academic star. And I saw him and his two kids. And I learned that in Ireland, the week with his Halloween is kids get off the whole week. They get trick-or-treating in the US for a few hours. There they get the entire week off in the whole country. So it's a week so people travel. So he's in Washington and Baltimore. And hadn't been here in a while and said things look about the same, which is what's the truth about Baltimore. And so it was great seeing him. And let's see what else. I can do like the Johnny Carson version. So, you know, I sometimes travel. So I'm going to San Diego. I'm speaking at the UCSD meeting on Thursday and Friday. Then I'm going to be next week in Boca Raton at the Baptist ER meeting. And the week after, I'll be in Las Vegas for the Hopkins CT meeting. If you haven't signed up, there's still room to sign up. It should be a terrific, terrific meeting. Myself, Perry Pickard, a bunch of Hopkins people, Mirage Hotel, which is where love is. Not love like love, but love like in the Beatles love. I don't want anyone to take anything out of context. But it's the 14th to 16th of November. It should be a great meeting, and you could register online. If you really run late, you can register in person. So it should be a great time, really good hotel rates. And Mirage is super cool. So it's a great place to be next to Caesars Mall. So it's pretty cool. So hopefully we'll see you there. Now, my talk today is about trauma. And first, let me say hello. I see Mark DePaulis from GE is online. Hey, Mark. And so that's in Boston or just outside of Boston. And Nadia Amici is watching from Nigeria. So that's something like 10,000 miles apart. So we got everything covered from Nigeria to Boston, Massachusetts. And Mark, I guess, probably, I'm sure, is a New England Patriots fan who are now 8-0. I'm a New England Patriots fan. It'll kind of be interesting because this week they play the Ravens in Baltimore. I think it's Baltimore. But they're playing the Ravens, surely. And the Ravens are pretty good. And New England always has a challenge when you have quarterbacks that are very mobile. And the Baltimore quarterback, if you've seen him, is really good. He runs around a lot. He throws pretty well, but he's really very fast. And so it's that unusual offense. And they usually do well. And New England defense has done great this year. So we'll have to see how New England does. And we'll have to see what else. And there's Fabio from Italy. Okay, so now we got the whole world covered. Anyway, so with trauma, I think, you know, obviously when we think about trauma, CT is the gold standard and the way we do things. Now, you could talk about trauma, so I'll just kind of break it up a little bit. When we speak about trauma, I always like to think about musculoskeletal trauma. So we have a number of talks on CTisus about trauma from a skeletal perspective, from using 3D reconstructions, from doing CT angiography, particularly for penetrating injuries, be it knife wounds, and more commonly in Baltimore, gunshot wounds. We talk about the use of CT for trauma from NVAs. So we look at the aorta, we look for acceleration, deceleration injuries and tearing of the aorta. We look for closed chest trauma. We look for pulmonary injury. In the abdomen, we look for all sorts of things. Remember the original work, Brooke Jeffrey, Mike Federley from San Francisco General, showing how CT changed the management of trauma, making it a lot less invasive. So whether we're looking at the liver or spleen or kidneys or the mesentery or the bowel, are all things we do evaluate. Now, in terms of protocols, and you know, in many centers, particularly when there's these multi-organ traumas, these MVAs, things like that. All of us have very, very fast protocols where you're basically scanning top to bottom and reconstructing everything. The key is getting the patient on the scanner and off the scanner and then triaging the information. It is a challenge for all of us because the number of slices you get is 3 to 7 or 8,000, depending how you reconstruct. But it works out very nicely, base of skull down through pelvis. And of course, when patients have multi-organ, we may be doing top of skull straight through the feet. So there's a lot of variability in how we scan. Key things that do remain the same is fast injection of contrast. We do not do non-contrast scans. We typically do arterial phase, occasionally follow up with venous phase. We try to use water as an oral contrast medium. If you can't give any oral contrast, the patient's out of it. We survive very nicely. That's not going to be an issue typically. Things we know with trauma, you want to do thin sections because you want to do reconstructions. It used to be you would scan the abdomen, then you would scan the spine. Now you scan in one fell swoop, and you target over the spine and reconstruct over the spine. The spine typically goes to neuro, the head goes to neuro, everything else the body people will typically do. So it's kind of a balancing act of being able to get everything together, both from the perspective of how we do the study to how we reconstruct. You need to have really good technologists because trauma patients need to be scanned quickly because the clinicians are standing right next to you. They need to know the answer. They really can't wait 20 minutes or even 10 minutes. So they're breathing on top of you. So the technologists are super critical. Vascular access and timing of the injection is super critical. As I mentioned, we like 5 cc's per second. That works nicely. 110, 120 cc's of contrast is really good ways of doing it. Typically, Omnipaque 350 or Visi 320. If patients are older and you don't know the history and you want to be safe, use Visi 320. It's safer. And if you don't know anything about the patient, you want to go with safety, speed, and the lack of even minor reactions, which can be problematic. In terms of trauma, we do a lot of 3D imaging, and that's true in the head, that's true in the spine, that's true in the extremities, that's true for angiography of these cases, or just looking at skeletal trauma. We will reconstruct many reconstructions, right? Because you need to target things. Sometimes you have the patient's arms by their side. Again, the key thing with trauma patients is make sure the patients are comfortable. They can't raise their arms. They can't raise their arms. Sometimes the trauma is in the arm. So you want to do is scan them by the side, reconstruct over the arm in question, reconstruct the abdomen. The thing about trauma, of course, we all know, sometimes from gunshots, you have penetrating injury. You kind of know what you might expect based on where the wound is. But for a lot of trauma, you really don't know. You kind of know the method of injury, or it was bad trauma, whatever the word bad versus good trauma is. And so you're looking at many different organs and you're looking for many different things. So I think one of the things that becomes very true in trauma, it's somewhat of a challenge because you're looking at so many different organs and it's so easy to miss things. A big thing about trauma imaging, of course, is the fact that you got to be careful not to be satisfied by search. So if you look and you find a splenic laceration and you kind of in your mind say, okay, splenic lac, I'm done. No. There could be a liver lac. There could be pancreatic injury. Could be kidney injury. Could be bowel injury. The thing about trauma more than almost anything is the number of different organs that can be involved. And so you need to look at the spine carefully. Sagittal views are critical. 3D reconstructions, CT angiography of vascular maps. There's just an unlimited number of things you need to worry about, and it's very easy to miss things. I think I've heard many people speak about it. Brooke Jeffrey does as well as anybody, and he talks about trauma and how he has a checklist because his experience in trauma is that it's very easy to miss things because you found 3 other things, but you missed the 4th finding. And sometimes it's that 4th finding that's the most critical finding. So again, it's a matter of really being very careful. I like the thin sections, sub-millimeter thick sections reconstructed. For the quick recons, you can do 3s or 5s, depending how fast your scanner is, because you need to get the trauma folks to look at the images very quickly with them. Trauma is prioritized in the ER, and that's true for us, and it's true for essentially everybody. You really need to do those patients quickly, and they need the results quickly. One thing we try to do, and all of us try to do, and not always perfectly successful, is kind of make certain that patients who get these pan scans really deserve a pan scan. If someone gets hit by a marshmallow on their arm, you don't need to scan the chest and the abdomen and the pelvis and do a runoff. So you need to have some common sense in selecting the right studies. And it's very easy for the referring docs to simply just check pan scan. So we do see that now, and commonly we see a lot of cases where it's a chest, abdomen, pelvis, but the patient had trauma to the face, and I guess there's a chance they had abdominal injury as well, or chest injury, but the patients aren't good historians. So I guess the answer is CT is so good and it excludes things. Why worry about missing something? With trauma, we're much more conservative now, but in some cases we need to be aggressive. So you want to be certain you can triage. And I think the reason CT has done so well in trauma is its ability to triage, figure out who needs admission, who needs surgery, who needs careful follow-up, and who could simply be discharged. So really, it's very, very cost effective. Although it seems like you were doing a lot more, it really isn't a lot more in terms of the cost to the patient. It may be the ideal thing to do. So we, like all of you out there, do lots of trauma. You said for trauma patients, there's no need to plane scan. I am right? Well, not a trauma. I don't do non-contrast scans in trauma patients. You asked the question, what does a non-contrast scan add by radiation dose? You know, you need to give IV. Arterial phase is critical because we need to see active bleeding. A lot of articles say just hemoperitoneum is important, but not that important. The importance is there active bleeding? And CTA with arterial phase imaging really will tell you that very nicely. So that becomes exceedingly important. We also do venous phase because sometimes the injuries are not seen on arterial and you want to get that venous blush. Also, we sometimes do delayed phase imaging. The only way really to exclude a process in the ureters or some change in perfusion of the kidney is with late phase imaging. On early phase, particularly if you're going in 90 seconds, the contrast in the kidneys is not going to be excreted at that point in most cases, or be minimally excreted. So you need to wait longer. So the trick is not to do 4 phases. We might do early, we might do late. So we really try to minimize the phases we do on patients. Again, the importance of looking at all of the windows from the soft tissue to the bone to the lung all become critical. It's very important to do that if you want to not miss any specific pathology. I mentioned oral contrast, just to go back over that. We typically do not give oral contrast in the trauma setting, just because patients are often not exactly with it. Routinely, I like oral contrast, positive or neutral. You want to distend the stomach, you get rid of all the pseudo lesions. So water is a good thing to do if the patient's cooperative. There's no downside, but it's not always necessary in the trauma patient. Let's see what else. And people have questions, it's a good time. Could you speak a little slow? I am Arabic, okay? I think you could watch this. One thing I can tell you, if English is not your native language, there's 2 things you can do. One is we'll post this to Facebook right after this, and we post it also on YouTube. On YouTube, you can go back and watch it with translation. I don't think you can do translation, to my knowledge, on Facebook. Also, when you go to YouTube, there's a way of speeding things up or slowing things down. You know, in college these days, kids speed up the professor's talk so they can hear it in 20% less time than it was actually given. But if New York is not your native language, or Brooklyn, New York is not your native language, then perhaps you might want to slow it down. Though I'm actually pretty slow compared to how I started 40 years ago. A question from Ghazi, arterial, do we start? I think arterial, you could scan with a fast scanner in the arterial phase all the way down. The slowest scanners is a bit tricky doing arterial from the top because when you get lower, you'll be venous, but you need to adjust accordingly. when you have a fast scan or a flash, any of the dual source type scanners where we can scan top to bottom in 30 seconds, it's really not a problem. What else? Venous injection. If we do venous, 70 seconds is a good delay. We don't do any second bolus injection. So that's something also. Chris Funk. Hey, Chris, you're in Philadelphia. I wonder why. Philly in the house. Are you in Philly or are you just Philly in the house? I don't know. Well, anyway, what other questions we have? Those seem to be the most of the questions. I think there's a lot of good articles on trauma. You need to have your protocols. There's a lot of different staging of trauma, liver, spleen. The importance with articles now talk about active extravasation. One of the reasons we like the arterial phase is you can see active extrav well. Active extrav now means often intervention. Non-active extrav means simply following the patient. So that is one good triage method alone. Let's see, Brittany, do you feel a CT of the neck is necessary for seatbelt sign? I think that if you had a seatbelt injury and that was it, you don't need to be doing the neck vessels. I think if you have gunshot wounds, stab wounds, pan trauma, then getting the neck is not a big deal. It's only a few centimeters higher, and we like to scan high enough that we don't miss an apical pneumothorax. So I don't see that to be a problem necessarily. So let me see. I'm waiting for a few more questions, and we're past the time. So if you have questions, you can ask me later, and we'll try to get back to you with those responses online or in person. Anyway, with that, I'll stop there. Thank everyone for their attention, and see you next time. Bye.